Hello, everybody. We are going to start. So this session is entitled Neutralizing the Risk, Managing Metabolic Acidosis and CKD. We have two speakers, each 40 minutes. We're going to save questions until the very end. And, a couple of housekeeping. Everybody by now should understand that you need to download the NKF app. In order to get CEU, you need to do a pre-test, post-test, and the evaluation. And you have until June 22nd to submit to get your CEUs and the certificate. So on that note, I will say presentation slides are available on the mobile app if the presenter has uploaded them and is okay with sharing. Did both of you guys, do you have? Yeah, okay, so slides are available. And with that, I'm going to introduce first Dr. Wesson. Dr. Wesson is Professor of Medicine, University of Texas, Southwestern Medical Center in Dallas, Texas, and the Dell Medical School, University of Texas at Austin. He is internationally recognized researcher in kidney acidifying mechanisms. He has translated his basic science studies to clinical studies and then to community-based studies examining the role of nutrition in population kidney health and kidney protective benefits of nutrition. He's authored and published more than 160 scientific papers regarding kidney physiology, more than a dozen books about kidney disease and hypertension, 18 chapters in scientific textbooks, and publications on cigarette smoking and its effect on the kidneys. That I was not aware of. Dr. Wesson received his undergraduate degree from MIT. He attended Washington University School of Medicine, earned his medical degree from Baylor College of Medicine, Houston, and completed his internal medicine residency and internship at Baylor College of Medicine. So on that note, Dr. Wesson.
Well, thank you for the opportunity to talk about my favorite topic, and I appreciate all of you who are here near the end of the conference to hear about my favorite topic. So my disclosures are I'm a paid consultant of Renibus, who is developing a drug for treatment of metabolic acidosis. So let's start from the top. What I would like for you to walk away with once you have finished listening to me. So first of all, I'd like for you to be able to identify the organ systems that metabolic acidosis adversely affects. Then to describe the approved ways by which metabolic acidosis and CKD, chronic kidney disease, can be treated. And then lastly, describe the benefits and the possible complications of the approved ways by which metabolic acidosis and CKD can be treated. So let's begin from the beginning, where this acid comes from. There are two major sources of the acid that challenges our kidneys to be able to get rid of it. First of all, it's endogenous metabolism. Just the way our machinery, body machinery works, creates acid that the kidney has to get rid of. But the modifiable part comes from diet. And of course, the kidney is the organ that has to excrete this so-called fixed acid. We'll talk about that in a second. And I have given an amount of acid, about 60 millimoles per day. That is a high dietary acid intake. It is higher than the so-called average dietary acid intake. But what I've put here is in the under-resourced community in which we do our work and conduct our research, where individuals have a very low intake of fruits and vegetables. This is the level of acid intake that these individuals have. It is very, very high, mostly because their diets are almost bereft of fruits and vegetables. So we'll get back to that in a second. So speaking of foods that contribute to our acid intake, I like this slide that my colleague and I, Dr. Garoria, put together because it illustrates the challenge that we have in terms of acid intake in modern society. So in the left part of the slide in the red are the acid-producing foods, that is, foods when metabolized by the body yield so-called fixed acid. On the right side of this, my favorite part of the slide, are the base-producing foods. And as you notice, most of these are animal-based products that produce acid. Most of these that are base-producing food products are plant-based, and those, the gray in the middle, are those that are neutral. Now, unfortunately, one of my favorite foods is at the top, hard processed cheese. Per gram contribute the greatest amount of acid production in our diets, and then followed by these animal-based products. If we go to the blue side or the right side are the plants, and at the top of the list are raisins. Per gram, we have found that raisins produce the most base per unit mass of the foods that we prescribe. So for those of you who really like cheese pizzas, you can see that acid that you get from it. But if you really like cheese pizza and you want to neutralize it a bit, throw some raisins on top of it. So this is a theoretical construct for the work, both the animal-based studies and the human studies from our group, that gives us a theoretical construct of what we think of what we call the acid stress continuum. So we're talking about metabolic acidosis, but let me tell you, we're talking about the extreme end of a continuum of acid accumulation in the body. So we think that the ideal, of course, is a normal glomerular filtration rate, or GFR, and a no or low acid diet, which is mostly plant-based diet. However, if we have a normal GFR and a high acid, we've been able to show that even that reduces the serum bicarbonate concentration a bit, but still within the normal range. So here is the normal range. But we think that with an increase in acid intake, acid accumulation is ongoing, and the lower the GFR, the greater the acid accumulation and the lower the plasma bicarbonate. But it is still mostly within the normal range. We think that only with this severe acid accumulation associated with a severely reduced GFR do we get this syndrome we call metabolic acidosis. So the point that I want you to remember from this slide is that when we say someone had metabolic acidosis, they're already at the far end of acid accumulation. And so before that, they have acid that has accumulated that we've been able to show that in and of itself is harmful even before the plasma bicarbonate concentration gets less than normal. So now, what is metabolic acidosis? Well, as a physiologist, I have to tell you that the definition of acidosis is a process, a dynamic process, where there is a net gain of hydrogen ion concentration in body fluids. Doesn't tell us what the hydrogen ion concentration is. It says that there has been a directional increase in the hydrogen ion concentration. And that acid that has been gained is so-called fixed acid, which is opposed to what we call volatile or gaseous acid that happens when we retain carbon dioxide gas. That gives us what we call a respiratory acidosis, but we're talking about now fixed acid accumulation, which gives us metabolic acidosis. So with that fixed acid accumulation, we have a reduction in serum bicarbonate because we have a physiologic ventilatory response The PCO2 goes down. And so in the steady state, what we would expect to see in an individual who has metabolic acidosis is a reduced PCO2, an increased serum hydrogen concentration, which is reflected by a decreased pH. Remember, pH is the negative log of the hydrogen ion concentration. So an accumulation of acid is reflected by a decrease in pH, and of course, a decrease in serum bicarbonate concentration. So the typical patient that we'll see with metabolic acidosis has a high dietary acid intake and a severely depressed GFR. Well, you don't have to go very far in the United States to find somebody that has a high dietary acid intake, just anybody, because that's the diets that we have. It is predominantly animal-based products that, and a relatively small amount of plant-based products, and so the algebraic sum of that is a net acid-producing diet. So arbitrarily, we have defined metabolic acidosis when there is a serum bicarbonate less than 22 milliequivalents per liter. But I've shown you that by then, you've already accumulated a bunch of acid. So when the bicarbonate concentration is less than 22, that's the severe end of this process that we call the acid-base continuum. So normal, and that still is a fight among nephrologists, what a normal bicarbonate concentration is, but most would suggest between 22 and 29 milliequivalents per liter. As I said, metabolic acidosis is less than 22. If you see someone that the bicarbonate concentration is less than 12, that almost always is an acute rather than a chronic metabolic acidosis. So we don't see that very often in the outpatient setting. This is most commonly seen less than 12 in the inpatient setting. So if there's one thing I want you to leave this conference with is that acid is toxic. An accumulation of acid in the body is toxic, and we and others have been able to show different aspects of that. It causes oxidative stress, which is damaging to tissues. It causes kidney and systemic inflammation, and it also causes insulin resistance. And again, we've been able to show that all of those things happen even before the bicarbonate concentration reduces below 22 milliequivalents per liter. So this acid accumulation is a toxic state. So it has three main organ systems that it adversely affects. Acid accumulation reduces bone mineral content. It makes them weaker and increases fracture risk. It increases protein breakdown that decreases muscle mass and function, decreasing physical function. I'm going to show you some studies related to that. And it causes kidney injury and possible progressive loss of function over time. And I say possible progressive loss because there's clearly controversy in the kidney community now as to whether treatment of metabolic acidosis favorably affects kidney health. I happen to believe that it does, but am respectful that we still need some more confirmatory studies. But I think there's less fight about the bones and the muscle. And so those two reasons in and of themselves are reasons to treat metabolic acidosis. We are still gathering larger scale and longer term studies to confirm whether or not indeed it favorably affects kidney health over time. So metabolic acidosis and chronic kidney disease is prevalent, and so this is a slide meant to illustrate that from one of my colleagues, Kalani Raphael, that looks at the percent of individuals on the y-axis, and on the x-axis, the levels of CKD remaining GFR, and as you know, the higher the number, the lower the GFR, and what this is meant to illustrate is that the lower the GFR, the greater percentage of individuals with metabolic acidosis. So metabolic acidosis is common in chronic kidney disease, and it increases in proportion the lower the GFR. So metabolic acidosis, first and foremost, epidemiologic study shows that it's associated with greater mortality. So for these individuals here who have a bicarbonate less than 22, the definition of metabolic acidosis, as I've told you, they have a greater mortality than higher levels of bicarbonate. And this is the only study that I know where the investigators were able to show that when treatment, mortality reduced. So we're going to come back to this study in a minute, but this is the largest study that I'm aware of treatment of metabolic acidosis with sodium bicarbonate, more than 700 patients. And the standard care is the light gray line here. The y-axis is the accumulative mortality event, and the darker one is those patients that were treated with sodium bicarbonate. And so these investigators were able to show over 36 months that treatment of metabolic acidosis was associated with reduced mortality. Acid accumulation is associated with impaired physical function. And so this is a study looking at grip strength in individuals with CKD, gait speed, and 6-minute walking distance. So when you look at studies that have been looking at muscle function, it's been difficult to show differences in grip strength. However, in this study, gait speed was less in individuals with chronic kidney disease, as was the 6-minute walking distance. So again, chronic kidney disease is associated with a decrease in physical function, and when these individuals are treated, one can show in objective measures improvements objectively of physical function. And so what I'd like to have you pay attention to is that this is the sit to stand test, and how many times the timing of which you're able to sit and stand, and that is time. The faster you can do that, the better your physical function. And Dr. Abramowitz and his colleagues were able to show that after treatment of metabolic acidosis with sodium bicarbonate, the sit to stand chair test was reduced by 1.6 seconds. For those of you who hang out in these kinds of studies, if you can show a 1.4 second improvement, that's considered significant. And so this is an example of physical function being depressed in individuals that have metabolic acidosis and improved when the metabolic acidosis is treated with sodium bicarbonate. In addition to physical function, there are studies showing a reduction in muscle mass. And this is the prevalence. So the higher the prevalence, the greater the proportion of individuals who have a reduction in their muscle mass. And as you can see, this begins around CKD3, that the more advanced the GFR, the more likely you are to have a reduction in muscle mass. And here are two studies in which treatment with sodium bicarbonate was associated with an improvement of muscle mass. So in these individuals, DeBrito, Ashers, et al., at 12 months were able to show greater muscle mass, and also at 24 months in those who were treated with sodium bicarbonate compared to those who were not. And in this study, the controls actually showed who received no alkali treatment, they had a reduction in muscle mass, whereas there was a slight increase in muscle mass in individuals who were given sodium bicarbonate. So evidence that muscle mass can also be reduced in individuals who have metabolic acidosis and improved when that metabolic acidosis is treated. So bone mineral density. We've known that for a long time. It decreases over time, and as you can see in the bone mineral density here on the y-axis, the lighter gray is the follow-up. I think this was 4 years later. Over time, at each of these stages, bone mineral density reduced. And when individuals who had metabolic acidosis who were treated with sodium bicarbonate, one can show here, these are the treated individuals on the right. There is a reduction in calcium excretion, presumably calcium coming from the bone, a reduction in this measure of bone resorption. This is a measure of bone resorption. It was reduced when the metabolic acidosis was treated. And of course, here is the net acid excretion being reduced with sodium bicarbonate. So again, bone health appears to be reduced in individuals that have metabolic acidosis and appears to be improvable when that metabolic acidosis is treated with sodium bicarbonate. Now, if you want to see some fights among nephrologists these days is when you get into whether or not it supports kidney health. So from epidemiologic studies, one can see that there is a greater risk for kidney function decline for individuals who have a bicarbonate less than 22. I don't think there's much argument about that from the epidemiologic studies. The argument comes from the interventional studies as to whether or not you can show an improvement in kidney health. So this is back to a study that we showed earlier that showed an improvement in mortality. These investigators looked at the progression, the rate of progression of chronic kidney disease. And I like this study. Even with its faults, it is the largest study that we have. More than 700 patients who were treated, all who had metabolic acidosis treated with sodium bicarbonate. And I've included this part of the slide here because we look at 12 months. These are the bicarbonate concentrations of the treated versus the untreated patients. And the thing I like about this study is that over these 36 months, they were able to have a distinct separation between the bicarbonate concentration of the treated patients versus the untreated patients. So at 36 months, there were higher bicarbonate concentrations in the treated versus the untreated patients. And when you look at the risk of a kidney event, the untreated patients are here in the gray, the treated in the darker. You can see that the kidney events, that is, the adverse kidney events were less in the individuals who were treated. And so I emphasize the fact that this study was able to achieve a great separation in bicarbonate concentration in the treated versus the untreated and yielded this improvement in kidney health down the line. This is the largest negative study that did not show an improvement of kidney health when these individuals were treated with sodium bicarbonate. And I've included the serum bicarbonate studies data on the left part of the slide. So at the beginning of the study, there was 3 months after the study began, the investigators were able to show a nice separation between the treated bicarbonate concentration in the serum and the untreated. But at 6 months, there was no difference. At 12 months, again, no difference. And at 24 months, the length of the study, there was no difference in the serum bicarbonate concentration in the treated and the untreated patients. And this shows here no net difference in the change in their kidney function over time. So if you ask someone like me, a physiologist that been studying sodium metabolic acidosis for a long time, if you're not able to show an effect of the treatment, then I'm not surprised that there's not an effect on kidney health. But that's just Wesson talking. But my point is, this still remains an area of controversy within the nephrology community, and I certainly agree that we need larger scales and longer followed patient studies to confirm that metabolic acidosis treatment does improve kidney health. So there are two approved approaches for treating metabolic acidosis in individuals with CKD: oral alkali supplementation, most commonly sodium bicarbonate, and reduced dietary acid intake, typically by giving reducing acid-producing foods and increasing base-producing foods. And our laboratory has focused a lot on the latter in recent years. So if we go back to 2013 as to when patients with metabolic acidosis, at least the recommendation for the treatment of metabolic acidosis should begin, KDIGO and KDOLKI said if you're less than 22, you should start treatment, most commonly sodium bicarbonate. So there was agreement between KDIGO and KDOLKI around that magic 22 milliequivalents per liter bicarbonate that I pointed out earlier. Later on, because of studies, some included from our lab, but not just our lab and others, they increased that level to 24 to 26. That is, recognizing what I showed you earlier, that there's acid accumulation even before you get to a reduction in serum bicarbonate concentration, that it is probably better to get the bicarbonate concentration to a more normal level. And so that was the recommendation in 2022. However, at the most recent KDIGO guidelines that focus, understandably, only on randomized control, relatively large-scale studies, and their conclusion was that we should treat only if the serum bicarbonate is less than 18. Well, when I saw this, my hair, the little left that I have, just went on fire. Because from my standpoint, that is just, we're doing our patients a disservice by waiting until their bicarbonate concentrations are less than 18. But in defense of them, of my colleagues who put this together, they were looking only at these randomized control trials. And so our conclusion, their conclusion, which is my conclusion, is that we need better, larger, and longer-term studies before we can make a clear definition as to when we should start treating. So these are data from my laboratory where we have compared in individuals who have CKD stage 3, those who were given sodium bicarbonate are those given fruits and vegetables compared to usual care, followed for 5 years, and looking at their PCL2 or the serum bicarbonate concentration over that time. Now, in the fruit and vegetable ones, we calculated what their dietary acid intake is, and we gave them fruits and vegetables enough to calculate a reduction of their dietary acid intake by half. And because we're dealing with, these are individuals who were under-resourced, our dietitian, thank God for her, she said, you know, Dr. Wesson, if you give these folks the prescribed amount of fruits and vegetables that you want them to have, because they are under-resourced, they're going to share it with their family members, and they won't get the right dose of fruits and vegetables that you want them to have. So she suggested, thank God she did, you need to give the amount that you want to give to the individual subject, you want to give to the entire family. So we calculated how much each individual in the study would have, and we multiplied that by the number of folks in the household, and that's how much fruits and vegetables that they got. So over time, there was a reduction in the bicarbonate concentration in those who did not receive any alkali. However, there was an increase in those who were given sodium bicarbonate and fruits and vegetables. So we were delighted to see that giving base in fruits and vegetables was not only helpful, but at least was comparable to the increase in bicarbonate concentration that was given, that was seen in those who were given sodium bicarbonate. And the real delight that we had was that we saw an improvement in preservation of glomerular filtration rate. So blue is baseline, the orange is 5 years later, usual care, and fruits and vegetables and sodium bicarbonate all show a reduction, but the reduction was less in both intervention groups. So we were really excited that we were able to show in this relatively small scale study, 36 patients in each group, that the intervention was helpful and fruits and vegetable intervention was as helpful, at least in GFR preservation, as the sodium bicarbonate. However, we got really excited when we looked at the blood pressure control and LDL cholesterol in comparing those who had sodium bicarbonate treatment versus fruits and vegetable treatment. So those who got the fruits and vegetable treatment at the end of 5 years had a lower blood pressure than those who got the sodium bicarbonate, and those who got fruits and vegetables had a lower LDL compared to those who got the sodium bicarbonate. So from our standpoint, given that fruits and vegetables, just like your grandmother told you, have a lot of comprehensive benefits, that from our standpoint, if it gave us a choice as to how the metabolic acidosis should be treated, we think the more comprehensive way would be with fruits and vegetables. So general strategies. How can we treat metabolic acidosis? Well, given that the fact that we all are eating an acid-producing diet, we can increase the proportion of base-producing foods like fruits and vegetables in the study participants that I just described. We can reduce the proportion of acid-producing foods like animal and products and refined grains. And by the way, when we talk in our community about reducing meat intake, it's not a very favorable response that we get from them. But when we say add fruits and vegetables, that goes over much better. And secondly, we can add sodium-based, thirdly, we can add sodium-based alkali like sodium bicarbonate, which is cheaper and preferred. And those that can't tolerate the sodium bicarbonate, you can use sodium citrate, which is more expensive and also a bit bitter. So general considerations for the most common treatment with sodium bicarbonate. It's cheaper and less bitter than sodium citrate, and the pills are preferred than is the powder. And so we often tell our patients, you know, this is just simple sodium bicarbonate that you're getting. It's like baking soda. And say, well, doc, can I just go to the grocery store and get some baking soda? Well, yeah, you could, but can't dose it very well. So we prefer the pills. The typical dose is about 0.5 to 1 milliequivalent per kilo per day. This is 42 to 82 milligrams per kilo lean body weight per day. Now, the typical sodium bicarbonate pills are 650 milligrams of sodium bicarbonate, and so this lower dose is about 6 pills per day for the average patient. And I emphasize that because I think the most common mistake that we make in giving sodium bicarbonate treatment of metabolic acidosis is that we don't give enough. I talk to my nephrology colleagues and they'll say, well, you know, Don, I started them on 2 tablets a day. I said, man, that's just a whiff. You need to give much more than that. And in our hands, most of our folks who get accomplishment of the goal serum bicarbonate we're looking for, they're closer to the 1 milliequivalent per day, which is about 12 pills a day. So that's the amount that is typically needed to get good if you're using sodium bicarbonate alone. We'll get to the fruits and vegetables in a minute. And so we divide the dose 2 to 3 times daily. So challenges, gastrointestinal upset and bloating. For those individuals who have sodium-sensitive states, that's a problem. They can retain the sodium and worsen edema. And back in the old days when we were using a lot of aluminum-containing phosphate binders, sodium citrate promotes aluminum uptake in the stomach. From our favorite way of treating, that is with fruits and vegetables, most fruits and vegetables are base-producing. The diets these are baseline diets that are recommended both for hypertension and diabetes. The DASH diet, the Mediterranean diet, that's just what is currently recommended. We don't have to make any changes there, but I don't know about you, but in the folks that we recruit for our studies, almost none are on any of these diets. And so we have to add those diets when they come into our studies. And the preference is to recommend whole diets rather than saying, eating this many strawberries a day. Just put them on a whole diet. The one that we prefer is the Mediterranean diet from our standpoint. That is the least acid-producing diet from our calculations. However, the DASH diet works as well. Problems, though. I'm sitting in a room with dietitians. Back 30 years ago when we started recruiting folks and started giving them fruits and vegetables in the way that I've just described, our dietitian's hair was on fire. And so over time, we had to be able to show that if we limited these studies to individuals who had GFRs above 30, and we kept them off of potassium, of drugs that limited potassium excretion, like mineralocorticoid receptor antagonists, then we can safely treat them. Such diets, however, particularly in the community in which I work, are expensive, and so we have to work around that expense to be able to give our patients those diets. And it is best done in consultation with a dietitian. I have to keep reminding my colleagues that our dietitian colleagues are our friends when we do these type interventions, and we need their input to do it right. So my proposal, the Wesson proposal, baseline Mediterranean diet for folks who have chronic kidney disease, supplementation with sodium-based alkali as needed if that is not enough to get them to the bicarbonate goals, and if you use sodium-containing alkali like sodium bicarbonate, you may have to use natriuretic agents like Lasix, furosemide, and the like to deal with the sodium retention. So let me stop there, and I'm told that we're going to do the questions at the end, but I appreciate your listening, and fruits and vegetables, that's the way to go.
Dr. Wesson, thank you so much for that talk, and we do have a lot of questions that have already come through the poll at the end. Next, it's my pleasure to introduce Catherine Dressel. Catherine is a board-certified specialist dietitian in renal nutrition, currently working in private practice. Her nutrition work focuses on chronic disease management, public health, and value-based care.
Good morning. Thank you guys so much for having me. Thank you, Lynn. It's a pleasure to follow Dr. Wesson. And I am not originally from here, but I live here currently, so I hope New Orleans has been treating you well. Nothing to disclose here. Learning objectives. So we are on the bottom 3 of the learning objectives for this session. We want to take a look at tools to implement all of the fantastic research that we just heard about. So we want to calculate and interpret that potential renal acid load, apply dietary strategies to increase the intake. So we're going to really dig into some of those strategies there, and also integrate medication and dietary interventions to optimize our treatment and outcomes. So step 1, what is the potential renal acid load? So this is an estimate for the amount of acid or base the food produces, and we have a couple of different ways to consider the amount of acid, but prowl is just one of them, and that's the one we're going to focus on today. What influences it? You can see we've got the protein, phosphorus, potassium, magnesium, and calcium, and that's going to be in an equation we actually look at to get an idea of that. So we know that higher dietary acid load can result in worsened metabolic acidosis and increase the progression of kidney disease. So it's certainly something we can target and manage. Though it's worth noting, prowl versus pH. It sounds very similar, but they are actually different kinds of acidity. We want to make sure, especially with patients, people frequently mistake things that taste acidic for things that produce acid in the body. So we will cover a lot of that in this session, but just be mindful that that is a common thing. When folks hear that, they think, oh, if it tastes acidic, it must make acid in the body, but that's actually not true, because a lot of fruits and vegetables, that's where we're going to find the alkali-producing food options. So it's actually backwards and counterintuitive. Just a few additional terms, because sometimes when you're reading the literature, you'll see a couple of different things. We've got the PROW, we've also got dietary acid load and net endogenous acid production. So the first two, the first and third can be used to quantify the dietary acid load. There are methods that you can look at, and in some studies they're used similarly, and in other ways they're compared, but it's just something that you want to be familiar with as a background option. There we go. So Dr. Rosen did an outstanding job of looking at the acid-base dysregulation and things we consider in CKD. So you've got this reduced renal acid load, or renal excretion, with declining GFR. And we do see, before you see those markers, the biomarkers, we do have more of a buildup of acid in the body. So we want to start intervening sooner rather than later. The development of metabolic acidosis can drive progression of CKD, and those clinical consequences are significant. So looking at the clinical relevance, we want to take a look at these because the research supports these benefits should be, we should be encouraging the management of metabolic acidosis to mitigate some of these things, delaying the progression of CKD, prevention of bone buffering, improving nutritional status, and of course the cardiovascular outcomes that were noted at the 5-year mark in that study. So it's important to really try and address some of these issues in folks who may not have issues or may not have access to dietitian. And there are a couple of barriers to this that we'll also talk about, but essentially nutrition and diet is underutilized in the CKD population in a lot of ways. So if we can focus on managing metabolic acidosis through PROW and other tools, we can definitely help improve our outcomes. So some of this seems a little redundant, but there's just a lot going on here. Why does PROW matter in CKD? So we're gonna look at these exact numbers and how you calculate this, and what does that mean for you as a provider, a clinician, versus what does that mean for a patient. So diet is one of the modifiable factors. That's why it's fantastic to really focus on that, because there's so much that we cannot change. Can't change necessarily medical history, can't impact age or even resources to some extent, but where diet is involved, we can absolutely impact that, especially in the cases where you're able to add fruits and vegetables through the studies, like Dr. Weston mentioned. And so we've got the evidence linking lower dietary acid load to these outcomes. Let's see. So I guessed correctly. I was hoping that Dr. Weston would hit the highlights on all of his really important research. This is just another slide from a different one, different study, atherosclerosis risk in communities. And they just found that it was higher acid load was associated with a higher incident risk of CKD, even after adjusting for all of these things. So we're coming up to the first poll question. But basically, interpreting PROW in kidney disease. Positive PROW, higher acid burden, right? So practical goals, and you're gonna see this a lot, this theme is gonna come up. We wanna reduce the dietary acid load rather than focus on a specific number to achieve, or even necessarily a negative number, because that can be actually quite tricky to achieve, like to actually have an overall negative PROW diet. So the goal is, like in the research, a 50% reduction in PROW was what they looked at, and they saw huge improvements in their outcomes. So I'm gonna take a look at that. So even a modest reduction in PROW has been shown to have benefit for slowing the GFR decline. We also have, for hemodialysis, the acid accumulation between sessions. We have dietary modification to complement that post-dialysis bicarbonate status and to complement the sodium bicarb treatment. PD, a little bit different because you have more of that continuous acid removal than hemodialysis, and also those patients may actually tolerate dietary liberalization a little bit better because of the nature of that treatment. And of course, you have increased protein losses in both of those modalities. So remember, the PROW is a dietary guidance tool. It's not a diagnostic biomarker. So we want to look at the serum bicarb. That remains the primary clinical marker for acidosis management. And so now we're coming up on our first poll. So, okay, it's supposed to say which food has the lowest prowl. And this is more of a baseline, just kind of getting a feel for the background. And there are a couple good choices on there. Give it just one more second. Is anyone brave enough to guess? Join me in the answer, toss out anything? Oh, I can't see anything on the side. Awesome. Who said spinach? Yeah. Nice. Look at that, awesome. And this is actually, we'll take a look at the reasons why, but there's not quite a trick question, but very close. So here's just some approximate prowl values for those particular amounts of food. It's a little tricky because I used what are normal serving sizes, where a lot of times you'll see these numbers compared per 100 grams. So 100 grams is not always the serving size of a given thing. But you'll see highlighted in the end is the approximate prowl, but if you take a look at that potassium column in the middle, the two answers that folks are going to be inclined towards are the higher potassium options. So when we get to the equation, you're going to see that protein and phosphorus are going to contribute to the increase of the acid production, and then potassium, magnesium, and calcium are going to be that alkali and the negative prowl contributions. So, how to calculate the prowl? And I do want to state this is not something we're going to send out to the patients. This is not something we're going to have them do because this is very tedious. This is more of an academic exercise and helping dietitians and physicians to plan the overall recommendations. So, what do? We go to something like the USDA nutrient database, and that screen right there is what you would see. And again, it's listed per 100 grams. So in some cases that is the serving, in some cases that is not. 100 grams of raw baby spinach is like 3.5 cups. So that's a sizable amount of baby spinach. But we'll go through these numbers right here. So this is pulled straight from the nutrient database. And it is worth noting, when you see these slides later, if you reference these in the future, the numbers, there's a little bit of a mismatch. And that's going to be, I thought about taking it out, and then I decided to leave it in because it is actually a really good reminder of the things that you need to consider. So you want to look at the serving size, the portion size, for wherever you're pulling your data from versus the serving size that you're calculating. And also, is it raw? Is it cooked? How is it prepared? Things like that, because that's going to change the amount. So if you ever glance at these slides again in the future and you say, why did she have two different values for the potassium on spinach? That is why. So hopefully it will remind you to be mindful of that. Let's see. So we have the equation for prowl. And I highlighted these things in different colors to try and make it clear. We're going to go through just a sample equation. So you take those values from USDA nutrient database and you figure out for the amount of the serving size, then into the equation it goes. So you can see the numbers that are additive, that are positive. We're going to be adding the protein and the phosphorus amounts, and then subtracting those values from the ones that have the potassium, magnesium, calcium. Those are going to be subtracting. And so this may be a clue. You already have the answers, but it's going to be those foods that are higher in protein and phosphorus, like the meats, like the cheeses, hard to find cheeses, that are going to be higher in the prowl. And you may notice the last three, the potassium, magnesium, calcium, that is going to be more in your vegetables, some in your fruits, things like that. So here's what it looks like, sample calculation for that particular serving of spinach. And so that puts us at negative 12.7 for that particular serving size for baby spinach. So is this something that you want to do with all of your foods and all of your patients? Almost certainly not, but it can give us a good idea of what foods are going to be the most impactful and how we can target them. So now we've got the calculation and we know what to do, how to find it. we will talk about what we can do with that information. So this is the real world clinical application, moving from the what is the potential renal acid load to what do we do with it. So positive versus negative. Positive prowl means that the food generates a net acid load on the kidneys, right? So negative prowl means it generates a net alkaline load. And we will continue to like separate out the foods that are going to fall into each column so that hopefully by the time you leave, you have a very good understanding of, at a glance, which ones fall where, so you can overall make stronger recommendations. But most animal proteins, many grains, dairy, they're gonna be positive. Fruits, vegetables, some legumes, they're gonna be negative. As far as target prowl ranges go, there is not really a universal validated prowl range for CKD, but all of our observational data and the research is suggesting, and in concordance with the KDOQI guidelines, we're going to move towards lower positive dietary prowl, or even negative. But from day to day, looking at the whole diet, I do think it's going to be a little bit tough for the majority of the population to maintain a negative prowl, and for their whole diet. So practical starting point, what does that look like? We want to aim to balance meals so that the overall daily prowl trends lower. And if we are able to assess the baseline, you really do want to figure out that baseline and then aim for that at least 50% lower to see those benefits we saw in the research studies. Is it going to be realistic for every patient? Not necessarily, may not be sustainable, but once we identify what the goal is, we can figure out some ways to get there. The critical limitation for prowl, it does not label foods as good or bad. That is extremely important to remember, because high prowl foods, there can be other benefits to them. They can have different micro and macronutrients that are beneficial, and a lot of dietitians practice in a way where patients are more accepting of dietary recommendations if you're able to make all foods fit or many foods fit, and it's less of a restrictive, overly prescriptive diet. So the goal here is to focus on the cumulative prowl of the total meal pattern or the diet and how we balance that with the alkaline foods. So, and as a practice point for anyone counseling patients, some patients catastrophize after learning that a favorite food is high acid or, depending what disease state you're counseling on, high sugar, high fat. We don't want that. We want to emphasize the dietary pattern over individual food demonization, basically. So we will take a look. We've looked at this useful tool, and now we will keep looking at steps for the to apply it to patients. Whoops, there we go. So this is just the at a glance slide. High prowl, low or negative prowl. And I grouped the low positive prowl with the negative here just because that's going to be more effective for planning diets, right? So if we are able to reduce the intake of the high prowl foods and increase the lower negative prowl, that's going to get us in the direction where we want to be. So what can we do? What are some easy ways to do this? I think prowl lists, which we're going to see some in a few slides, that's a pretty easy way to do it. It's just if you employ them cautiously, because sometimes when given a list, patients will focus only on what's on the list, or they'll see the higher column or the limiting column, and again, catastrophize or start to get kind of down on themselves. So it's important to counsel and to educate on how to use these lists. And I recommend conceptualizing prowl just kind of in that fruits, vegetables, legumes, but especially fruits and vegetables, versus these other options in terms of how to balance the intake. And so for the positive prowl, like the magnitude of that, consider the overall prowl of the diet, not necessarily of an individual food. So these pre-calculated lists, they're helpful for clinicians, helpful for patients, saves you from having to calculate it manually, which I don't recommend, though that is certainly an option, and we'll talk about that in a few slides. But basically, we want to direct the patients to these resources to help them figure out what to eat, as opposed to having them perform multiple calculations and carry around spreadsheets and overthinking everything they're eating, because that decreases the sustainability and also the patient tolerance for it. So, yeah, negative prowl foods can help reduce that overall prowl, and it's important to maintain that this is not like a moral framing of the foods. It is a physiologic one. This is a reflection of what's happening in the body. When you eat this, this is what happens specifically to the kidneys. So it's not a moral or a qualitative assessment of any individual food. So since the pearl is derived from one of those 5 nutrients we mentioned, the protein, phosphorus, potassium, calcium, and magnesium, it obviously doesn't capture the full nutrition quality of anything. It's just one factor to look at. So we want to use this tool to guide balance, not to drive elimination of foods from the diet. And now, let's see, how do we make this more concrete for patients, for providers? Using Prowl to guide dietary planning. You want to integrate it into patient assessments, either using that 24-hour diet recall. You could use food frequency questionnaires. If you do this a lot, pattern recognition develops pretty quickly. You do not have to calculate every time because, again, it's not about exact numbers in this case. This is one of those things where a more qualitative overview of, are we eating more fruits and vegetables, are we eating fewer of those highest acid-producing things, that's going to be the most helpful. So counseling approach, we want to frame the dietary shifts as increasing the alkaline proportion of meals rather than achieving a specific rigid Prowl number, because that's not going to be useful in regular everyday practice, and it's not even really what they were doing in clinical trials. So that is what we want to focus on. And also, we will talk about some more strategies, but as you assess what the patients are eating, we want to give them tools to help them move forward. So you want to assess where they are, how they think about food, how they select their meals, and how can we make that easier for them. So the plate model is a good option. If you want to just focus on filling half your plate with vegetables and fruit, that's going to get you closer to that lower daily Prowl without requiring calculations, and it's a little bit easier. It's visual, and it can be a more useful way to present that to someone who is not interested in counting everything. However, if you do have certain patients very much like data and they like tracking, Chronometer has a built-in Prowl tracking function, which very useful for dietitians. I'm not sure I would necessarily recommend it for all patients, but it can be helpful if they're entering their food and it's putting out that data. So now that we know how to use it and how to calculate it, let's see how you guys do on a question about whole meal choices instead of just individual foods. So based on what you've learned about Prowl, that's weird. I hope you can see the rest of the choices, because that is not the right answer. Which of the meals would you recommend to minimize dietary acid load? Can you guys see the other options? Oh, no. That's awful. Oh, no. Okay, let me go back. Oh, yeah, no, and they hid that from my slide, too. So, well, that is depressing. The point of this, the choices were things like cheeseburger and french fries, which not the choice, not the recommendation, because that's going to be higher in animal protein, meat, cheese. You've got the refined grains. I think the other option was something like a salmon with quinoa and roasted vegetables, which was supposed to be your decoy option. That was supposed to trick you into picking that one, because it seems like it's a good option. But the answer for this one, there was a spinach salad with chickpeas and a bunch of other vegetables, and the answer is going to be that one because it's got the plant-based protein and the higher vegetable intake, especially that spinach, which shows up a lot because it's just so negative in the Prowl score. So this is right, and throw some raisins on top, right? Sounds delicious. Like 2 for 2 on these slides not working across this conference. So applying the strategies. Oh, this slide comes up a little silly. Let's see. So Dr. Wesson did a good job of focusing on this and walking us through that. The Western diet is very high in acid, and the plant-forward diets, which have some acceptance, are not, I wouldn't say universal acceptance. I agree with that experience that talking about cutting back on animal protein or eliminating meat, it is not widely received as the thing that all patients want to do. But there are ways that we can use those changes to improve the Prowl score. So This is one of the more clinically nuanced balancing acts here. So we want to meet the protein requirements, but also minimize the dietary acid load. And so you've got animal protein as that major acid source. We want to focus on balancing, and of course there are different recommendations for protein for different states. So you're going to have a lower protein recommendation for CKD to limit that nitrogen burden on the kidneys, and higher in dialysis patients just because you're going to have those losses and just the increased needs. So plant proteins tend to have lower PRAL values. We're going to try and increase their intake, because lower PRAL relative to equivalent parts of the animal protein. So a blended approach may be your best bet here, combining small amounts of high quality animal protein. So that's going to be more of like the lean meats, chicken breast, lean beef, fish. I mean, beef is never going to be at the top of the list based on its numbers, but it's certainly better than, say, the heavily processed and cured meats. So it was just, the point is to contrast whole foods that are close to their natural form versus very, very processed, like sausage, pepperoni, deli meat types that are higher in sodium, higher in added phosphates, all of those things. So one caveat for CKD though, the high potassium plant proteins, like legumes, nuts, things like that, do require individualization based on your patient's specific labs, specifically their serum potassium, though there are some cooking techniques that can be beneficial to mitigating that. So everything should always be based on the individual patient to enhance patient acceptance and sustainability, as opposed to applying a one-size-fits-all. So let's see, the protein acid load is one reason that certain dietary patterns are gaining in popularity. Let's take a quick look at the overall dietary patterns. So Mediterranean diet, DASH diet, definitely the best choices for this. If you have a patient who is open to a vegan or vegetarian lifestyle, then a lot of your work is done for you, because they're already going to be willing to eat those lower PRAL plant-based proteins. And that whole food plant-based is that acronym. That one is also gaining in popularity, but it does not beat the Mediterranean or DASH in terms of accessibility. So yeah, whole food plant-based is comparable to vegan, but also like specifically whole foods, not just, you can't really get to it through excessively processed foods. It also has limited oils. It's like a very like a niche kind of subset of the vegan and vegetarian diets. Reduced protein diet, very important in CKD. Plant-based protein versus animal protein. This is actually an emerging hot topic in CKD and nutrition. And we want to make sure that you are trying to increase your intake of the plant-based proteins while managing your intake of the animal proteins, because there's still a place for it, especially if that is going to be the thing that makes it so your patient is able to continue to follow these guidelines. You want to meet them where they are and make recommendations to improve overall. In the Kidoku guidelines, we want more fruits, we want more vegetables. That we already heard earlier. So let us hop over to the big challenge. So for your dietitians, this is arguably the most important slide, because there's a lot of nuance in the alkali versus potassium issue. So you've got the fruits and vegetables, which are alkaline forming but potassium rich. And if you recall from the equation, that is part of why they are alkaline forming. That potassium is a big part. So being higher in potassium is what makes them lower in PRAL score. So what do we do with that information? Well, first of all, not all CKD patients are hyperkalemic. So we want to individualize. We want to look at their labs, their trending. We don't want to treat them as a single lab value. We want to look at them as a person, what their preferences are, what medications they're taking, which ones contribute to increased serum potassium. Look at all of those pieces. So, and of course, historically, fruits and vegetables and even legumes are among the most restricted in CKD because of their potassium content. So we want to find a way where it is safe and preferred for the patients to increase their intake to gain the benefits of managing metabolic acidosis through this lower PRAL score. So it creates a genuine therapeutic conflict that we really can't ignore. But I think it can be mitigated if you take a look at the different options. So dialysis modality, in your peritoneal dialysis folks, we see a lot of those who skew a little bit lower in the potassium. So this could be an excellent opportunity for you to educate and counsel towards increased fruit and vegetable intake there without much issue or detriment to their numbers. Conversely, in hemodialysis, if they're already running very high on the serum K, it's something you'd want to do a full diet, like deep dive, figure out where those sources of potassium are coming from, look at their medication, look at the whole context of everything, because there's a lot of benefit, not just for serum potassium, a lot of benefit to increasing the fruits and vegetables, as Dr. Wesson mentioned. So we want to do the things that are going to benefit them overall, we're not just treating a lab value, we're not just treating the serum potassium. Yeah. So let's see. Oh, there we go. Renal appropriate alkaline food choices. Obviously, one option would be the lower potassium vegetables and fruits, though of course those are going to be a little bit lower in that base producing capacity. So, and that's gonna mean it's gonna be a less negative per hour, closer to 0, as opposed to more negative. So it's an option. You also have the preparation methods. So leaching, cooked versus raw. Leaching, probably all the dietitians in the room are very familiar with leaching potassium from potatoes, like double boil method or soaking them overnight, so that you can help your patient who really loves potatoes get to enjoy something that they love. So that can reduce the potassium content significantly, which again, there's gonna be a trade-off. It's going to reduce some of the PRAL negativity capacity, but it might help them maintain these dietary changes overall. And also, worth noting, so deep fried foods wind up getting called out on some of the slides, and why is that? I just wanted to talk for a moment about how does deep frying change the PRAL? So water loss is going to concentrate the nutrients, and of course the PRAL score is based on the nutrients in that equation. So if you think about deep frying something like a potato, we're no longer talking about leaching potassium. We are now comparing raw potato and French fries. So if you think about that, the deep frying removes the water, so the nutrients are more concentrated. And again, some of that's going to be the numeric bias. 100 grams of raw potato is not the same as 100 grams of French fries. So there's more water in 100 grams of raw potato, whereas in the French fries, less water, denser in protein, minerals, fat, things like that. So it can make the PRAL appear more positive, more acid forming, simply because it's more concentrated. So that's just a thing to keep in the back of your mind, that these numbers, they are not static, they're very dynamic based on how much you eat and what form it's in, and a handful of other things. Though when in doubt, you can always just toss the raisins on top, right? Also, so potassium, the reason you'll see difference in PRAL scores, the potassium may decrease, with the blanching, with soaking or leaching. Since the potassium is what's strongly alkalizing, losing the potassium makes the PRAL less negative. It's not the actual frying, like those French fries, to pick on them again, it's not the actual oil. The oil is neutral, as discussed, but it's more the other changes. And also, those fried foods sometimes, or in many cases, have more phosphate additives. So things that are heavily processed or fried may have, as an ingredient, added phosphates. So commercial fried foods can have breading additives, sodium phosphates, phosphate preservatives, things that can increase the acid load. So that's going to be your breading or your coating on fried chicken, or your packaged snack foods, or again, your French fries. So portion control as a strategy tends to be very beneficial because it helps to not focus on elimination. Patients are often more willing to make modifications if they can still enjoy some of their favorite foods. And of course, the strategy needs to be tailored to the individual patient, but it's beneficial to consider where they're coming from and what things are their non-negotiables and what things are they willing to work with you on. I threw in a slide about alkaline water just because I think this is important. And I think that you may or may not recognize the brand, but it's been labeled alkaline water, so I think it fits in the rules. So is it beneficial? I've had patients in clinic whose family invested so much money in alkaline water, thinking that this was going to somehow save their family members' kidneys. And they claim it neutralizes acid in the body. So from a dietary standpoint, I don't think you're going to see much of a benefit, and certainly not in terms of the acid load on the kidneys, because if you're taking in this more alkaline water, it's going into the stomach where all the acid is, and is neutralizing pretty rapidly. And also, just from a numbers perspective, if you were to take the actual equation for PRAL and put in even larger amounts of these alkaline waters, you're going to see the numbers are negligible. Like, there are some added minerals, but it really doesn't move the needle in terms of the PRAL value, so you can't alkaline water drink your way to lower dietary acid load in the body. Meal planning examples. So we've talked about it a couple times already. Focus on gradually shifting the meal composition to increase the alkaline forming foods and respect a moderate protein restriction. So what does that look like practically? If they have their meals built around a large portion of meat, then we increase the vegetables, we increase the fruit, and then we work towards decreasing the serving size, the portion of that large amount of meat. And that way, you can still enjoy the things you love, you can still help them to find a way to cook for their families, because that's another major complaint. Folks who have issues and are counseled toward these particular guidelines, they say, my family's not going to eat that. What do I do? And I'm not making 2 dinners. So by making it more acceptable to the whole family, especially if your primary meal cooker is the one who has the kidney disease, it makes it more tolerable and makes it more sustainable for everyone. So in the same way where they increase the fruits and vegetables servings that were provided in the research study, we were kind of taking the whole family along for the ride, and it's beneficial. So everybody wins. So also, what else we're looking at? We're adding more vegetables, trying to kind of dial back on the refined carbohydrates, choosing lower PRAL grain-like options, like quinoa, and yeah. Keep moving. Okay, so more practical strategies. That's just a little snip of what it looks like in the Chronometer app on the advanced option, like the upgrade. So you can see you put in, it allows you to track your food for the day, and then it takes a look at like where are you landing. So if you have someone who likes that kind of thing, this is a little bit higher level. I wouldn't necessarily recommend it for folks who don't even like to keep a food log. But if you have a very tech-heavy person, like there are patients these days, especially since we're seeing earlier stage CKD and like younger and younger patients, if you have someone who's very into the tech and tracking steps, likes tracking their food, likes documenting things, this could be a good option to help them really conceptualize what those numbers look like and how their diet is actually in the balance of the PRAL. So options, we've got meal planning with a target PRAL. Definitely don't focus on a specific number. That is going to frustrate patients. And it's just less practical. It's especially since the numbers are dynamic. I mean, you could have a spreadsheet, you could input everything, but I don't recommend it, especially since serving size, it's a dose response curve. So you're eating more, you're getting more of either the acid or the alkali. Recipe substitution, we talked about that. You want to swap out some of those higher PRAL things for lower PRAL options. And food list and charts, that is coming up, and I think hopefully these next couple slides will be useful for you in the future, should you ever refer back to this. And also, we're going to talk about the plate method again, just because that can be very helpful for low activation or low health literacy patients. So let's see here. Food list, negative PRAL. Again, this is all for 100 grams of food. And another caveat, it's going to depend where you get your information and also which edition of the database, like the USDA micronutrient database. It's going to depend on which edition you're using. And so the source data will impact it. But basically, if it's on this list, you should feel free to incorporate it, and it can be beneficial to your overall PRAL planning. But again, they're estimated per that equation. that we saw in the very beginning. And remember, negative prowl, these are all pretty good things, but when we get to that positive prowl, remember it doesn't make it a bad food. This slide is a little bit less exciting. Also, butter. So those oils are mostly, they're all right around 0. Butter, again, it's 100 grams. So 100 grams of butter is like 7 tablespoons. So that's like half a cup of butter. So that's, for the most part, that's not casual use of butter. I mean, probably. I mean, maybe if you're baking, but then you're not eating the whole thing. So that's, I just wanted to throw that in there. It's not representative. It's not like butter is driving up the issues. And if you're eating that much butter, it probably is showing up in other lab values, other considerations. Your cardiologist probably isn't happy. So we got the low positive prowl I pulled out just because I think even though it has like a positive prowl value, not everything needs to be eliminated or demonized, because we want to look at it in the overall, where it sits in with everything and how things are balanced out. And of course, the numbers can vary. Highly positive list. You're going to see all those processed foods, a lot of cheese, a lot of meat, cola and soft drinks on there, and that's because those added phosphates. Leave it for you. So here's some Creole. Since we're here, some Creole and Cajun examples of like higher prowl options. So hopefully you guys have all enjoyed a muffalata in your time here. That's going to be on that higher prowl list. You've got the cheese, you've got the cured meats, you've got the refined grains. Andouille sausage, like in a gumbo, also on the higher prowl list. And I am certainly not saying don't eat these. Please, unless you have severe metabolic acidosis, I encourage you to enjoy some of these foods while you're here. And you've got your boudin and your fried shrimp po' boy. If all else fails, toss the raisins on, sure. But do not tell anyone here I said that, because I would like to keep eating in restaurants here. On the lower prowl side are those the classic food items. I got as close as I could. Red beans without sausage will do the job. And that might be advertised like a vegetarian or a vegan red beans. Got collard greens. Okra is in a lot of things, if you like okra. Merleton, it's kind of like, it's a vegetable really specific to here, and a handful of other cuisines that are not standard American diet, but it's kind of like it's like a squash when it's cooked, but it's a little bit crispier and kind of like texture of an apple when it's raw. So you may see it in your stuffed fish or as a side dish casserole. And of course we have Creole tomato salad. So let's see. More practical strategies. Reducing portion of protein. We've talked about most of these. Monitoring the phosphate additives. You want to limit the processed foods and just be mindful that phosphorus isn't listed on the nutrition label, but it will list in the ingredients phosphate additives, and that should be a red flag that it may not be in line with our current goals of increasing fruits, vegetables, and decreasing dietary acid load. Here is that plate method, just in case anyone here is not familiar with it. So that's that really quick and easy way, half the plate, fruits and vegetables. And then once we've got that accepted, we can focus on what's in the grain, what's in the protein. Like we can modify those choices, we can move towards the less processed and the better options. But step one, just get the fruits and vegetables on the plate, get them on the table. I hope that you guys will refer to this in the future. I hope this is helpful. Anyone who has to counsel patients about specific things like this, I hope this will be helpful to you in the future. I included a lot of food options. So breakfast is definitely the most neglected meal for vegetable intake. Most people don't eat any vegetables at breakfast. There are no vegetables in the breakfast buffet today. Nothing. It is absolutely a dearth of vegetables and options. So here are some ways that you can increase the vegetable intake in your breakfast foods. So, and you've got a lot of savory options, we've got some sweet options. You can, egg whites are a good option. Egg whites in a whole egg, also an option. Tofu, if tofu is not your thing. Smoothies are actually a pretty great way to sneak vegetables in. Like this has cucumber, because we were aiming for low potassium, but you could also slip in some like frozen riced cauliflower to really fluff up your smoothies, or a handful of spinach. There are a lot of ways to sneak veggies into what you're doing in a way that does not feel like drudgery, like you're being forced to eat vegetables for breakfast. So, also cabbage. Cabbage is another one that slips in very nicely, and you'll see that over the next couple of pages. But quinoa, good option, quinoa or oatmeal. You can do that in a savory or a sweet version, and this oatmeal with grated zucchini, that's kind of in the family of like zucchini bread in the way that it doesn't really, it's not really like you're having a vegetable for breakfast, but it blends in nicely, so that can be one of the best practical acceptance strategies to increase in small amounts so that we're just moving the needle meaningfully. Lunch. Lunch is a great option for how to increase vegetable intake. Like salads, grain bowls, soups, all of that, great option here. And those are just some suggestions for different ideas, because it's easy to say, have a salad, but like, what do I put on the salad? Like, people need ideas, and it's also very helpful if you can make it attractive looking. If you can find a way to make it look like this is more appealing, then that can help displace like fast food burgers or fried chicken sandwiches or things like that. If what you're offering looks better, if what you're educating on looks more exciting, that really helps the patient acceptance. So it's also, if we're looking at the overall daily prowl and the acid load, this can be a great way to just really put some negative numbers up on the board and offset maybe what you're having later in the day. Let's see. And if you're cooking something and potassium's a concern, you'll make sure you want to toss the broth or don't drink the broth, because the potassium's going to leach into it, similar to how we like leach the potatoes or dialyze potatoes. So just remember that. Oops, missed dinner. Dinner, cauliflower got its own section because there's so much you can do with it. Though I would call that like an upper level food substitution. Because someone who is used to having like a whole catfish for dinner, I would not present cauliflower as like the new swap. It may not be as well received, but if that's the case, you want to look at your patient, you want to assess where they are, and maybe we slowly work with increasing the vegetables. The vegetables make it onto the plate, and then we start adding in plant proteins, and then we phase down some of the animal protein. So, I mean, partial animal protein is also up there as a very reasonable way to mitigate some of that dietary acid load. So yeah, dinner is where a lot of the animal protein dominates. So we've got a lot of leverage for how we can restructure that to improve the dietary acid. Snacks. I don't know about you, but I've had so many folks, it was just, they're tired, they're on dialysis, cheese and crackers are an easy go-to snack. They're portable, and unfortunately they are not great for your dietary acid load. Same thing with your CKD patients who might have 4 or 5 or 6 specialists and they're on the go and they've got a lot of doctor's appointments. It's just easy to grab. So what we need to do is have some easy and reasonable suggestions for what they can take with them. And these are all vegetable options. Fruit is also right there and very portable, many of them in their own containers. Like apple, easy, doesn't need anything special. For counseling, we want to educate on grocery shopping tips and reinforcing those cooking methods that promote vegetable intake, and also being mindful of potassium. You want to address any common barriers. And so look at your patient population, and see what the problem is. Do they not like the taste of vegetables? Because a lot of people grew up with a family member who did not make great vegetables, and they think they're terrible. My husband grew up thinking that Brussels sprouts were terrible. They were tiny little cabbages, and they were awful because he only ever had them boiled. So boiled Brussels sprouts, not my favorite, don't smell the best. So figure out what's specific to your patient and find a way to help them increase their intake of things that we want them eating, which it just might be an experience, an exposure, an education issue. Okay. Okay, diet medication. Eat the vegetables, fruits and vegetables, and we have potassium binders for diet. Yeah, we're just gonna cruise through these last ones. Your interdisciplinary team is what matters. Make sure that you are working with your physician. If you don't have, if your physician or local nephrologist don't have dietitians, reach out, establish those relationships, do what you can to offer this service for the patient, because there's a lot for us to offer. And yeah. So straightforward. We've been over these. Key takeaway, combining targeted dietary counseling and pharmacologic support and systematic monitoring, we can meaningfully improve the acid-base status, slow CKD progression, and improve both quantity and quality of life for our patients. And I've got a lot of references. You're going to see Dr. Wesson in there a lot. And this is my 11-week-old making her debut at the conference. Thanks, guys. Yeah, are we staying up here?
Yeah, awesome. You guys take a seat.
Okay.
Thank you both. They were wonderful talks. I've learned a lot. And it always comes down to, we've got a lot of work to do as dietitians, always. We have a lot of questions, so I'm not sure we'll get through all of them. If you're agreeable to staying after it a little bit, if people do have more. But let me start from the bottom. This is for Katie.
Oh.
Because this came through during your talk.
Oh, I see.
How high in prol are nuts? Should we recommend limiting them with patients?
I think it's going to depend on the balance. Like you don't want them living off of nuts, but that's also for a couple of different reasons with phosphorus and potassium. Some of them are higher in prol. It's going to depend on portion size. Like, are they having just a handful, or are they consuming significant quantities? So it also varies a little bit by the individual nut on those food lists. You can see some of the lower prol ones are on the green list, and some of the higher prol ones are on the red list. But I would take a look at that and also make sure to assess how much they're consuming.
Great, thank you. Next question for you, Katie, is have you heard of hydrogen water? I've had a few patients ask me about it. Is it detrimental to controlling acid?
I have not heard of hydrogen water.
Dr.
Me
West?
either.
No? Yeah, I don't think I have. Anybody in the audience? Yeah?
That was my question, but everything I found, so like, I guess it was to see what it really was, I couldn't find much information. So I was wondering if y'all had known. But a few patients asked me about it last year.
Nope.
Yeah, we'll look it up.
Okay, Dr. Wesson. I'm going up at the very top of the list, but Katie, there's still other questions too I'm trying to get through. For patients with end-stage kidney disease, would you advise to liberalize potassium-containing foods and give Localma or Veltassa, which shows these also improve bicarb levels?
So let me answer in this way. In our studies, we look for folks who were already demonstrating that they could handle a potassium load without developing hyperkalemia. So we follow folks in our clinic who had not developed hyperkalemia. And as I mentioned, we limited our studies to those individuals whose GFRs were 30 and above. So we did not include anybody whose GFR was less than 30. And very importantly, other than the ACE inhibitors and the ARBs, we limited the simultaneous intake of drugs that limited urinary potassium excretion, like the mineralocorticoid receptor antagonists, non-steroidal anti-inflammatories, or NSAIDs, those type of things, those types of drugs. So one should really be careful. If individuals have already demonstrated that they are prone to hyperkalemia, then I would be reluctant to put them on a high fruit and vegetable diet that challenges their ability to excrete potassium.
Okay. Next question. What effect, if any, do phosphate additives have on increasing the acid load of a food?
As Kate told us, those phosphate additives do add to the acid load. So that's one of the reasons why the processed foods are those that we should be avoiding, because that added phosphate, which is done for commercial reasons, also adds acid load.
And that's not always apparent in tables that we look at for food.
That's correct.
Unfortunately. Katie, What type of protein powders or drinks would have a lower PRAL score?
It's going to be the ones that are plant-based, like the pea protein or
Okay.
the other like seed-type proteins. Whey protein is actually very higher in the PRAL score. So, yeah, the flip side is you have to be very careful with which ones you're recommending because they tend to be a little bit grittier. And they've gotten better in the last few years, but like plant-based proteins, they do not mix as nicely. Sometimes they are grittier. You may need to reduce the dose to increase in acceptance if protein consumption and meeting targets is an issue.
Yeah, I actually use one that is a pea protein base I really like.
If it's
A
good, you
lot.
should tell us. You should share your
I will, yeah.
recommendation.
Let's see. Katie, for you, tips on how to incorporate the idea of PRAL into your practice for better patient adherence?
Yeah, I mean, I think the
kind of one
latter
thing.
section of the slides covers a fair bit of
Yeah.
that, but, yeah. I would say a good place to start would be the plate model.
Okay.
That's a very good entry point for everyone. Beyond that, you want to assess the patient and their particular interest. And is it just a curiosity, or are they actually really wanting to dig into like specific PRAL? How aggressive are they planning to be about all this? So,
Okay. Dr. Wesson, is there any evidence to show that persistent, uncontrolled metabolic acidosis affects cardiac muscle?
I'm aware of some basic animal studies that shows that challenges contractility. I'm not aware of human studies. Some of my colleagues may know the answer to that. Bob, do you know? Thanks, Bob.
Thank you. Dr. Wesson, how should you approach doctors when CO2 levels are between 20 and 21, and they usually do not adjust the bicarb bath or prescribe oral sodium bicarb tablets?
Let me address the second part first. If the pre-dialysis bicarbonate concentration is persistently low, then giving between dialysis doses of bicarbonate helps to get the pre-dialysis bicarbonate concentrations up. The studies that have relied on changes of the increase in the bicarbonate concentration in the bath have not been that successful without causing trouble. So that if you raise the bicarbonate bath, you get the pH up into such a high level that in and of itself can be difficult. Okay. So the studies would suggest that a better way to handle the bicarbonate concentration, the pre-dialysis bicarbonate concentration in dialysis patients, is not by manipulating the bath. The better way is to give alkali in between dialysis treatments. I don't know of any studies, we haven't certainly conducted them, of whether or not you can do so with dietary means. My guess is that a dietary intervention would be helpful, but there are studies that say that if you give on non-dialysis days, you give sodium bicarbonate, that helps in the pre-dialysis bicarbonate concentration.
Okay, thank you. Go. And if anybody has any questions that they want to approach the microphone, please do so, but I will continue reading off questions that came in during. There were a lot of them. I'm not sure we'll get through all of them. Let's see. For either of you, which stage of CKD do we need to be aggressive about PRAL? As early as stage 1 or stage 2?
I was going to defer to you.
You know, the earlier the better. You know, we have studies that we've published that said people with CKD1, if you put them on a high fruit and vegetable diet, you can show benefit. They have slower progression with their with CKD. So for me, the earlier the better. You get a benefit whenever you start.
Good, okay. Did it matter how the patients cook or eat the fruit and vegetables? Most patients don't like salads.
In terms of potassium, yes. In terms of other things, no. If they don't like salads, you can certainly put them together in those grain bowls or soups or stir fries. Like, there are a lot of options. Anything that you would recommend generally for increasing fruit and vegetable intake is going to be a viable option here. It's just the ones where potassium is modulated that you're going to want to be mindful of if that's an issue.
Yeah, I agree with Kay. And I would add an anecdotal study. You know, collard greens are a culturally really important part in the African American diet. But the way that we typically prepare them is not healthy with salt and fat back. And so we had a patient in one of our studies that said, because we were recommending that she'd eat collard greens, but we were saying prepare them in a sauteed way rather than boiling them, and she was very resistant to doing that. But a few months later, she grabbed me in the hall and said, "Dr. Wesson, we did that sauteing thing, and my family won't eat them any other way."
That's cute. How long will it take to correct the CO2 levels if you recommend a diet rich in fruit and veggies without alternating between CO2 baths and oral medication?
We haven't looked specifically at how long it took, but in our studies, we were able to see an increase after 3 months of a diet.
Okay. Good.
So at least we would say that 3 months would be enough time.
Okay. Are you concerned with the amount of sodium patients ingest from the sodium bicarb pills at the higher dose?
Yes, I am. And so that's why our preference is start with diet, and whatever, if you're still short of your goal, then add the sodium bicarbonate tablets.
Okay, let's see. Which preparation of vegetables are preferred, frozen or canned, in parentheses, no salt added? Most of my patients cannot afford fresh foods, unfortunately.
Yeah, access is a huge issue.
Absolutely.
Yeah, I would say it depends on what they can afford and what is available in their area. So frozen, just as nutritious as fresh, as long as it's not frozen in any weird sauces. So you gotta make sure you educate them to be mindful, like read the back of the nutrition data and see, is there any added sodium, any added sauce. But if it's plain frozen, comparable to fresh. If it is canned, and that is what they have access to, that is better than not eating the vegetables.
Yeah.
And of course, you can drain the liquid and rinse them to reduce some of the sodium. And the important part is getting those fruits and vegetables.
Great.
I have to add to that's a real challenge in the area of Dallas, in this low-income area that we do our studies. There are no grocery stores there. And so most folks are getting, if they get fruits and vegetables, it's from the 7-Eleven type stores where the quality is very poor. And so that's a real challenge for low-income communities.
Yeah, and it goes along with the idea of food deserts
Absolutely.
in areas. Yeah, and
Absolutely.
it's a big problem. It was mentioned that refined grains increase the hydrogen ion. How do whole grains affect this?
On the Pearl list is a little bit lower. I mean, it depends. Like, things like bran are going to be very high because you've got the phosphorus and protein, like especially the phosphorus driving it up. But yeah, the refined. It's going to vary a little bit by the individual food because it's impacted by those minerals and the amount of protein, the amount of phosphorus.
Right.
So
Okay. What dose of fruit and veggies did patients need to eat to see a positive outcome, i.e., how many servings did they need to eat?
We didn't measure it in terms of servings. We did it in terms of cups per day.
Okay.
And the minimum was a net increase of 2 cups per day.
Rachel?
Yeah, I'm going to throw out a hypothetical, actually, for Catherine. So you made a lot of great points, but there's a lot of things we keep in the back of our minds to be like, it might actually be better than the equation makes it look, like when we're talking about phosphorus additives versus the natural sources of phosphorus. Like, we know we don't absorb as much of those. So even though the whole grain, in theory, has a little bit more phosphorus, but not as absorbable, maybe the Pral is actually better than the additive version, even though the calculation says it might not be. 'Cause
I
it
would agree with that.
Doesn't account for that.
I
maybe
don't know we have great data, but I
hypothetically.
absolutely agree with that, yeah, especially what we know on like phosphate
Consideration,
additives.
at least for people who are wondering about those things.
Yeah,
Yeah.
no, that's another one of my like pet projects.
Yeah.
I agree with that. The inorganic versus organic phosphorus, like naturally occurring versus those additives, those are highly absorbable. And I do think that's probably going to lead to an increased number in the prowl. But that's probably where that the process refined grains are coming in. So yeah, I agree with that. I don't know, because it's complex and you've got all the little the different components that go into the score, and of course there's some variability in intestinal absorption, like you said. But I think that encouraging folks to eat more of the whole food, closer to whole food and how it arranged or how it originated in nature, is probably going to wind up being better for you in terms of dietary acid load.
Yeah, I like your phrase, Kate, demonizing food. I think we should avoid that. And my dietitian colleagues have educated me over the last 40 years. Emphasize what you want them to eat rather than demonizing what you don't want
Yeah.
them to eat. So eat this rather than saying don't eat that.
Yeah.
I think we have a few more questions. Thank you, audience, for staying, and to the presenters. For the increased muscle mass with improved acidosis, was this with or without physical activity also?
That's a good question. Bob, can you answer that? The question was the study that showed an increase in physical activity with bicarbonate treatment of metabolic acidosis, was that combined with exercise or physical activity?
Okay. Okay, thank you. Because 12 pills increase pill burden, would it be as effective for the acidosis if they opened the capsules and mixed it in food, if they ate all the food?
Ooh, that's a good suggestion.
Yeah.
I don't know, but it sounds like something that would be reasonable to try.
Let's see. There's a comment, because there is limited data showing high potassium foods increase serum potassium. In my practice, I tend to liberalize dietary potassium and focus on root cause of the high serum potassium. Last question, will we get?
Can I say something?
Yeah, go ahead.
I agree with that, and I think the research moves in that direction, but not every nephrologist is on the cutting edge of science and is aware of these things. So a lot of folks, especially depending on where they are in their continuing ed, are not necessarily on top of the dietary intake of potassium foods versus serum potassium. So I'm inclined to agree with whoever said that, but it's also important to be mindful that you're a nephrologist. If they are very much practicing like high potassium foods are bad, you don't want to come out of the gate, because then it's going to harm your working relationship, and then you're not going to have access to the patients. You gotta really work and see with what they're practicing too as well.
I agree.
Okay.
Caution is preferred.
Okay. I think the last question is, will we get the handouts?
That's what I was gonna ask.
Yeah, okay. Yeah. And while there is this, and it's kind of interesting for either of you, in hemodialysis, what potassium level threshold is recommended before switching to a 3K bath to allow more liberalized fruit and vegetables? That might be a hard one.
I don't know if there is a specific one. You know, we get nervous above 5.5.
Yeah.
Sure.
Yeah, and I know in my company, our protocol, basically it's a 2 and a 3K. And there are specifics and ranges and what's recommended per protocol when you switch baths. So we stay away from the 1K and the
Stay away from
4K.
1 to 4.
Yeah.
Yeah.
Okay,
Between 2 and 3.
Rachel, you have another?
Well, it's going to be more of a comment on the handouts thing, sorry, just because we're having glitches with the technology and the app and things, sorry. So if you're not seeing the things that you're looking for, Jessica, so sometimes you have to go back out of that screen and back in, try again, because I just did it now and it appeared for me, so just keep trying. Because even like the pre-test, the pro-test, sometimes I have to even log
Yeah.
out of the app, come back in,
Yeah.
just thank you, let us know as questions come up and be patient with us, so. But Sorry.
I
Your
did
slides are
have-
wonderful. Thank you for sharing your handouts.
I did have a comment. I have not heard anything about PROW, and so it was really impressive because we're always trying to teach people how to prevent, preserve, and delay kidney disease, and they get tired of hearing eat more fruits and vegetables, but when they can actually see numbers, and just like you pointed out with the water, they're looking for the data, like alkaline diets, acid-base, they're looking for the information, and now we can speak their language
Yeah.
and put numbers to it and show them kind of in the back doorway how important fruits and vegetables are and give them ideas of ways to incorporate it. So I really found this very informational to apply towards helping people protect and preserve their kidneys. So.
Great, thank you.
Very good, thank you.
I think that will wrap it up. Thank you both for staying over a little bit longer. They were wonderful presentations, and I always learn, so thank you again.